First of all, I would like to thank all of you for joining today's online meeting on the revision of the Blood Directive. We will be discussing how to enhance plasma collection via increased regulatory efficiency. Although I still can't welcome you in person at the European Parliament, I hope that day will come soon. It is a pleasure for me to host this online event in this very critical topic. As I guess all of you know, plasma-derived medicinal products, PDMPs, are made from plasma donated by healthy donors. And these medicines are essential for around 300,000 Europeans who rely on them to treat a variety of rare, chronic, and potentially life-threatening conditions, such as primary immunodeficiencies. However, Europe has not been collecting enough plasma to meet the growing clinical needs, and this is an urgent, long-standing worry. We import almost 40%, 38% of plasma from the USA. The European Commission is momentarily working on revising the European blood, tissue, and cells legislation to take into account the most recent technological and scientific developments. This revision is welcomed, very welcomed, since it will allow to address the current issues, including the need for more plasma collection in Europe. And it allows an increased regulatory efficiency reflected in the revised legislation and the new technologies and new research and knowledge to be taken into account. Because in the past 20 years, significant advancements have been made to increase the quality and safety of PDMPs. As such, the current legislative revision represents the unique opportunity to ensure that the regulatory requirements, including donor eligibility criteria, do reflect science and technology-based advancements as well as societal changes. I'm looking very eagerly forward to hearing from regulators, patient representatives, policymakers, and industry what the more efficient regulatory framework would look like, with the ultimate goal to increase plasma collection and provide treatment to the patients in need. Especially given the growing clinical need for PDMPs, I'm confident that this meeting will lead to a very fruitful discussion and concrete suggestion that we hope will be reflected in upcoming legislation. In collaboration with stakeholders as policymakers, we have a crucial role to play ensuring that all patients have access to medicines they need, and unnecessary regulatory barriers to this are removed while the safety and societal issues are taken into account. Without more ado, I will give the floor to Mr. McGuire and to our speakers who have done us the honor of being present today. And I shut my mouth and open my ears, and please, the floor and the guidance is to you, Mr. McGuire. Thank you.
Pietikäinen, thank you so much. Very kind of you to open the meeting today. I know you're going to stay with us for the duration as well. So we'll look forward to speaking with you later on. Now, the rest of the session today, we're going to begin with a series of short presentations and giving some perspective from each of the dimensions that MEP Pietikäinen just mentioned, to regulator, industry, patient, and so on. So the first speaker today is from the European regulators perspective, is Dr. Karmin Saadat. He's a GMP inspector at the Institute of Surveillance at the Austrian Federal Office for Safety in Healthcare. Karmin.
Yeah, thank you so much for the invite. I'm glad to be here and share our experience with, the legal framework and inspections in general. As you said, I'm with the Austrian Competent Authority, and I'm mostly going to talk about the Austrian legal framework as part or embedded in the EU regulations. What I'm going to talk about a little bit, and I was asked to present the situation from a regulator's view, and it's I've come up with way too many slides, so I'm just going to briefly throw out some topics for further discussion. As far as I understand, this is more a forum for discussions as just plain talks. So I'm just going to go over a few topics that I think are important to discuss. Maybe so the differences in blood establishments, whole blood and source plasma. I'm going to talk about the Austrian legal framework as an example in the context of the EU Blood Directives slash legislations. This is going to be why the Austrian legal framework. It's one of the, as you know, it's one of 4 member states. And correct me if I'm wrong, but this is the number that I had in mind. I think it's Hungary, Czech, Germany, and Austria, which actually have source plasma or commercial source plasma sites operating in Europe. And so I'm going to talk a little bit about the legal framework, why that is, or what the reason for that is. And I'm also going to briefly brush on the regulatory oversight during the travel restrictions, which now have lasted a lot longer than most of us have expected. And I think we did a pretty good job in coping with the situation. Briefly going to discuss this too. Next slide, please. So everybody is probably familiar with the differences of whole blood and source plasma. I just wanted to point it out again and throw it out there just as a reminder. And this is pretty much also the basis for the differences in the regulations, or the slight differences where source plasma, and when I say source plasma, I refer to mostly or only commercial plasma centers, so plasma apheresis centers, and as opposed to whole blood establishments. So the differences are quite obvious there. So for whole blood, you have whole blood on the left side here in this diagram, and this is a very simplified diagram, but it's just there. What I'm trying to say is here, what the main differences are and what the reasons are for differences in legislation or rules. So for whole blood, there's a processing part which leads to different types of blood components, and plasma is one byproduct that normally is generated during these processing steps, centrifugation and separation normally. And so I wanted to point out that not only source plasma establishments, but also whole blood establishments provide plasma for fractionation also. It's I do recognize, of course, that whole blood establishments contribute to a lot lesser extent, and you probably know more as far as the numbers go, but the amount is a lot less there, of course. But they do also provide for fractionation, and most of the products go to transfusion then. Now, one important difference here is that at the manufacturer or before actually manufacturing plasma to final products or final medicinal products, there's a viral inactivation process at the manufacturer, or multiple processes, multiple methods used to make sure that viral load is eliminated. And also there's hold times at the manufacturer for 45 to 60 days, and in order to take action in case of subsequently something is found out that a unit would be unsuitable for production. So that gives a little extra safety there, as opposed to blood components that go directly to transfusion. Of course, there's also viral inactivation steps for those blood products in some cases, but generally speaking, these are pretty much the main differences. I tried to also line out the differences or the different responsibilities of the blood establishment and the manufacturer. So within the blue dotted line here on this diagram, there's the manufacturer and the responsibilities of the manufacturer, where normally transportation and of course the fractionation is the responsibility of the manufacturer. The collection and freezing is normally in the responsibility of the blood establishment, and that's pretty much the foundation of the different rules that apply at certain different steps there. Storage it's not 100% accurate, so storage could be also part of transport, and then it would fall under manufacturer's responsibility. But generally speaking, this is what we're looking at. Next slide, please. Annex 14 of the EU GMP guidelines, manufacture of medicinal products derived from human blood or plasma, states that for all subsequent steps after collection and testing, that means processing, including separation, freezing, storage, and transfer to the manufacturer, the requirements of Directive 2001/83/EC apply and must therefore be done in accordance with the principles and guidelines of good manufacturing practice. So to clarify this and to also clarify the rules that are laid out in Directive 2005/62, which talk about the quality management of blood blood components in general, the good practice guidelines for blood establishment has been founded, and this kind of puts together all the GMP rules that actually apply to plasma. So the issue here is that plasma is not exactly does not 100% fall under good manufacturing practice, but it's not 100% comparable with whole blood establishments. So this is where the good practice guidelines comes into effect. Next slide, please. And and this is just a list of the European relevant legislation and guidelines. So the Commission directives, the good practice guidelines for blood establishments, the EDQM guide to the preparation, the use and quality assurance of blood components, and Annex 14 to the EU GMP guidelines. So this gives the whole framework for all European member states pretty much to run and operate their blood establishments in general. And of course, there's national legal blood acts, and they may be more stringent than the directives, but at least have to meet the requirements of the directives. So, and this is where different national law comes into place. Next slide, please. Now, for the legal framework in Austria, where source plasma establishments are operating, there are a few differences in the national law that take into account the different processing steps of whole blood and source plasma. Now, one very important and crucial point is, I think, the remuneration. So for whole blood, it's strictly not allowed to pay the donor any amount of money. And for source plasma, there's only compensation allowed, no profit. The exact amount is not strictly defined, and this gives a little bit leeway and a little bit of discussions every now and then. And we're currently discussing whether or not we should put in a cap there, just to make sure that that this could always still be regarded only compensation, as the rules are a little vague, I should say, maybe right now. So this is in the process of being discussed right now. So and also what I was going to point out here is that with authorizations of new source plasma establishments, this also leads a little bit to some competition and rivalry between whole blood and source plasma establishments, where whole blood establishments sometimes are a little concerned about the potential crowding out of donors, as they see that this is not a level playing field where some donors get paid and some donors are not allowed to be paid. In the course of, we've had, I think, to this point, three new plasma centers within the last 10 years, and they all opened up in the last 2 years. Yeah, I think that's accurate. Last 2 years, so just recently. And we have to date not seen a situation where crowding out happened. We've issued temporary authorizations just to make sure to be able to react. Because of course we are also concerned about the supply chain of whole blood products. There, to date, we have not seen a negative effect. So, but we keep monitoring this, of course. Of course, testing requirements are a little different, and testing donation frequency is different, as plasma is regarded less stressful to the donors, as red blood cells are being returned to the donor, so that gives way for a lot more donations with source plasma than whole blood. Austria currently has 50 donations a year allowed, and the donation amount depends on the weight of the donor.
Okay, 1 minute.
Oh, okay. I'll speed up a little bit. Next slide, please. Yeah. So yeah, that's pretty much the main message that I was trying to give. Now, one other topic that I was going to throw out there is the PMF status, and I know that PPTA were very concerned about the new, especially new centers, to be maintained on plasma master files, and therefore not causing any disruptions of continuous supply. So what we did is, and this is taken from the notice to stakeholders from EMA and the Commission, and basically what we did is we found a way to implement distant assessments for new centers, just to make sure that that plasma master file holders are able to put up new centers and to be able to put those on the plasma master file and to just keep their supply going. And then also we do distant assessments for existing plasma centers, and therefore we feel like we have a certain degree of surveillance, and at the same time we're giving the plasma master file holders the chance to maintain their centers on the plasma master file, and therefore keep sending their products over to Europe for further fractionation, basically. Next slide. I think this is pretty much just a continuation of the previous slide. And the last slide, please. Yeah, so this is just an overview of how many, or an estimation of how many centers we do inspect, and we have oversight of around 20 plasma centers national, a little less than that, and around 20 whole blood establishments national in Austria. And we have oversight of around 400 third country blood establishments. That contains all the individual sites, but that just kind of gives you the idea of how big a plasma provider the United States are there. Just to your previous point that was stated in the beginning. Yeah.
Thank you, Karmin.
Sure.
That's great. Thank you so much. So just one quick question before we go to the next presentation. The impact of COVID crisis, how did you adapt, or are there the structures that you put in terms of temporary measures? Do you expect those to continue after the crisis disappears?
Well, we're very much looking forward to going back to normal and to inspect on-site. I think we gained a lot of experience now during the crisis, but generally, I think the on-site inspections are going to be the primary form of what we're looking at. We may implement certain circumstances and certain circumstances such distant assessments again, but generally we're looking forward to going back to normal on-site inspections.
And any other practices that, as a consequence of this adjustment, have formed part of a learning process for what can be changed, what can be made more efficient?
Could you say that again? Sorry.
Are there any changes or lessons learned during the crisis that you think will be put in place on a permanent basis?
As far as what would you suggest?
Well, in terms of inspection or process, any the bureaucratic process, anything which helps make it easier for the producer to be regulated, or for the ease of access to the market.
I think what we've seen is we've learned a lot about what can be done remotely and what cannot be done. So we may use technology and document reviews in the future a little bit more and more efficiently, and then ask for the appropriate documents before time, and then use that experience maybe just to be more efficient. Definitely. Yeah.
Thank you. Excellent. Stay with us, and we'll have you back in a few minutes for the panel discussion. And our next speaker today is taking the European Commission's perspective. It's Stefan van der Spiegel. He's the head of sector at the Substances of Human Origin at DG Sante. Stefan, good to have you with us today.
Thank you, Ryan. Good afternoon, everybody.
Floor's yours.
Okay, so can I then have the next slide, please? Yeah, so I'll take the next couple of minutes to introduce you into the EU legal framework of blood, and as mentioned, the plans that we are having to revise that, and what that could mean for the access to more plasma in the EU, and also what not. I think it's important to acknowledge the right position and role of this blood EU legal framework. But maybe to start, first a step back, and that is, why do we at EU level regulate this field of blood donation collection, and also for plasma donation collection? Well, actually that dates back to the 80s and 90s of the last century, when we had several outbreaks and significant public health concerns with contaminated blood products, including plasma derivatives, across the EU for many countries, and that dates back to the beginning of the HIV crisis, but it also concerned hepatitis, and there were other communicable diseases like variant Creutzfeldt-Jakob that was important also for tissue transplantation, and those risks actually have driven the member states to give the EU a mandate in this field to set high standards of safety and quality. Next, please. And actually, we've done that in a dedicated legal framework on blood tissue cells. Those have been adopted in the years 2002 and 2004, and basically it addresses the safety and quality of all the steps that a substance of human origin, as we would call plasma, has to take recipient body, and this those steps include donation, collection, testing, preservation, storage, transport steps, processing, as Karmin already explained, and then human application. However, it is important to acknowledge, next please, that when the collected substance of human origin are going into an industrial manufacturing process, and with an intention to place on the market, which is basically what the plasma manufacturers are doing, that at that moment, the legal mandate or falls under the pharma legislation for those later steps. So a bit as Karmin explained in one of his first slides, the original donation collection steps fall under the blood legislation, the later manufacturing steps and putting on the market fall under the pharma legislation. So in that sense, it's very good also that you have organized this event with representatives of both sets of authorities here. Next. So back to the blood legislation, the reason why we are revising it is for, there's several actually. I'm not going to go through them all, but I'm sure most of you will know that we did an evaluation of those frameworks, and the blood framework actually dates back to 2002, and we really identified 5 key shortcomings. And I just want to draw your attention to, next please. Next, yeah, to this last concern, which is actually indeed a concern on whether our supplies for BTC are not too vulnerable for interruptions. And indeed, plasma is there one of the key elements, and as already mentioned in the introductory word by Ms. Pietikäinen, we are highly dependent in the EU on plasma collected in the US. If we want to increase that collection and supply within the EU, then it's also important that I point you to a second shortcoming of the evaluation, and that's the fact that the donors at this moment in the EU are not well protected through our EU legal framework. And obviously, if we need more donations and more collections, it's a prerequisite to have that well fixed, so that we can trust on donors, and donors can trust on the system, that they will be ensured their own safety in this system. Next. Yeah, so this to illustrate already a bit what was mentioned before, we as Europe and the whole planet is quite dependent on the plasma collected in the US. So 5% of the world population is collecting 60% of plasma. This meant for Europe that over 30% of the plasma derivatives are manufactured out of plasma collected in the EU. But actually there's a correction to be made there also now, because a big part or an important country in that situation was the UK, which is no longer part of the EU, and which which for reason of variant Creutzfeldt-Jakob had not collected any plasma themselves. So obviously the UK is a big country and makes a quite significant part of that percentage there, and being no longer part of the EU and starting their own plasma collection, that figure will have to be adapted. But anyhow, I think it's clear that we are highly dependent on the US, and that we need to address this. Next, please. And the options that we are exploring in our possible revision of the EU legislation is double. And there's measures to strengthen the monitoring of the supply, so that we have a good, accurate, and timely picture on the supply, and possibly also on the shortages that are expected. And in case for such shortages, also there are measures proposed on emergency supply. Next. As you had already the question before, I think it's important not to have a look at what COVID means for plasma and plasma supply in the EU. I think on the first, obviously, the key concern is a risk for interruption, and driven by changing collection volumes. We saw a significant drop in collection of plasma in the EU, and as in the US at the beginning of in the first wave of COVID pre-summer 2020. But we have also seen that by summer 2020, those levels of collections seem to have largely recovered to the pre-COVID levels. It is, however, important to monitor the expected impact on what that reduction in collection will mean for the eventual availability of the medicines. And there's more factors to consider than just the collection there. There's lead times between collecting and having the medicine available. There is manufacturing steps. There are also reserves that were and are available with many of the manufacturers. So all those elements need to be taken into account, and our colleagues in the European Medicines Agency, for that reason, are doing a regular exercise with the main manufacturers, the plasma manufacturer holders, to monitor the developments that they expect. And obviously, in that context, it's also important, it already came up a bit, that we, from our side, what we can do is think about regulatory flexibility wherever that is possible. I think we already discussed with Karmin the possibilities to be more flexible temporarily on inspections. Also, quarantine periods have been brought up, also an issue within the pharma part of the legislation, and within the SOHO part or the blood part of legislation, the donor deferral criteria are the main elements we can look in. Next. But COVID also, in context of plasma, might bring some opportunities to increase supply. I think there has suddenly been an increasing awareness of the value of plasma, driven a bit by the potential that is there for COVID-19 convalescent plasma. That has got some attention. Also, new donors have been attracted, and as Commission, we also have used a European support instrument to help member states increase their collection capacities. Next. So back to our legal work. So we are in the middle of this process of impact assessment and revision. And like any other EU legislation, we need to follow some key steps there. And the first step that we had to do, and I'm sure most of you will have seen, is that we present a roadmap. How are we going to do this impact assessment? Many comments have come in on that. That was in December last year. And the second important step was a broader public consultation and a more target technical consultation. And there we had over 370 submissions. That was last week was the deadline. So I cannot yet at this point tell you what are the key messages in there. And we also are supporting the revision with studies to gather further evidence. Two in particular, one for the impact assessment, one on more on the data related aspects. And in those studies, we will also reach out to all the key stakeholders on key issues through dedicated workshops. And one obviously will also be relating to, or some of them will relate to the sufficiency and the supply. Next, please.
1 minute.
Yeah, I think I'm almost there, Brian. Maybe just worth mentioning the feedback we got in December, the first 80 reactions on the roadmap, which was quite some. Actually, I think there's a lot of comments that confirm that there's plasma dependency and that we need to take measures. And some are mentioned, regulatory flexibility, but also at the end of the chain, avoiding the off-label use when and also at the beginning of the chain, initiatives to do more donations, compensation campaigns, etc. Also a question about having more separate rules for blood compared to plasma. There are also some comments about the fact that our measures are mainly focused on monitoring and emergency supply, but maybe not really tackle the supply dependency issue itself. And that is also a bit related to our EU legal mandate. As I said in the beginning, I think we need to be aware of what we can do with a blood legislation and what we cannot do. So I think we are exploring some things there, but we still need to see how far we can go from a legal basis. Next. And that is why I also wanted to point to a workshop we organized 2 years ago together with the European Directorate of Quality of Medicines, which was exactly focusing on how we can increase plasma supply. And there's a whole set of recommended actions there. And I'm not going to go through them, but I just want you to be aware that it's not just about the European Commission and the EU legislation. It also is about getting more coordination, common overview on the availability of the therapies. It's also about the need for national plans, about the need for collaborations on optimal use with manufacturers, organizational aspects in blood establishments, and also big role is there for patient associations, donor associations, and professional societies. So this is something that we're not going to just fix with 1 or 2 legal changes. This is something that will require a broader effort across the chain from all the actors that are involved and play a role in this sector. I think that was my last words on this. Next, maybe to see. Yeah, good. I don't think I need to mention. There's also Pharma Strategy, which is good. It's also covering shortages because it allows us to work on both sides at once. The first part of the legislation on SOHO, on blood, and the second part on pharma. And I think that really was my last slide, Brian. Thank you.
Thank you, Stefan. Excellent. Stefan, just a quick question on, you started the presentation looking at the differences between the EU and the US in terms of production distribution. The mutual recognition element and the agreement and GMP inspections for plasma and plasma-derived medicines between the EU and US. Is this planned for reevaluation in 2022? Do we expect to see any change in that?
I'm not really in a position to answer you on that, Brian. I think firstly, as said, it's about GMP inspection, so it's under the pharma legislation that we need to look there. And secondly, the only thing I'm aware of, this is of course part of a broader high-level political discussion. So I'm not able to comment much on that.
Okay, thank you. Stay with us for the discussion later on as well. Excellent presentation. Thank you, Stefan. Now let's go to our next speaker today. Is on the patient's perspective, and it's Leire Solis. She is from the International Patient Organization for Primary Immunodeficiencies. She's the Health Policy and Advocacy Senior Manager. Leire, good to have you with us today.
Hello, Brian. Thank you to the organizers for inviting IPOPI and having the patient's voice within the panel. So I've been asked to say a few words on the current challenges for patients, and I think actually Stefan has raised it very well. The main challenge for patients with PIDs, and I would imagine it's the same for other patients with relying on PDMPs, is the risk of shortages and not having access to the treatment they need. So patients with PIDs currently have experiencing difficulties in accessing their IG, either because there's no enough plasma, or because there's a problem in the development of the medicine, or because there are market withdrawals of a product or a company, or a combination of some of them or all of them. So basically, this means that patients are sometimes having many challenges. And at IPOPI, we ran a survey to understand the impact of COVID-19 in the availability of IGs. And out of the 13 European countries that replied, 7 of them experience and continue experiences shortages, either at national level or at hospital level. And this concretely means that patients with PIDs need to change brands with the potential adverse reactions and time needed to adjust to the new therapy. Either they need to change route, but they also need to increase duration between the treatments and decrease the dosages, and that's worrying. And in some countries, basically, new patients cannot be accepted for treatment, or they can actually not have the treatment. So that's what the situation is for many of our patients in Europe. So if we were to look at the upcoming blood legislation and see what would be the desired changes, we have 5 main points. The first one would be the development of guidelines, policy, and legislation actually based on facts, science, and experience. We commend the efforts of international and European organizations when looking at reviewing their guidelines to adapt them to the current state of art of science and technology. Our second recommendation would be to avoid wastage of plasma. I mean, we cannot afford continuing wasting plasma. In 2016, the Commission report highlighted that 7 countries reported not recovering plasma from hot blood donations for plasma for fractionation. So, I mean, we've been encouraged, for instance, by the recent lift of the plasma ban for manufacturing of IGs in the UK that happened recently. And actually, our hope is that the ban can be lifted for all PDMPs in the country, so that manufacturers can proceed with the development of such so much needed medicines. In terms of upcoming policy, we would support the view that donor deferrals are driven by evidence and reviewed according to the latest scientific and industrial development. And we support, for instance, as Stefan said, it's a collective effort. It's not just at European level. So we support the current WHO revision of the guidance of blood donors for looking at the deferrals with the latest evidence, and applaud the inclusion of patient organizations in such revision, for instance. As a third point, we would encourage the development or strengthening of plasmapheresis programs as a very efficacious way of increasing plasma collection. And for instance, we welcome the initiative of the EU grant for funding the purchase of plasmapheresis equipment, and hope that this equipment, once the COVID-19 pandemic is under control, will continue to be used for the collection of plasma for fractionation. As a fourth element, we would favor information campaigns, and we would, just as an example, we commend the European Commissioner, Ms. Kyriakides, for her statement in the last World Blood Donor Day, where she mentioned and recognized the importance of plasma. And we think that more targeted campaigns towards the different donor profiles and targeting blood components and plasma for fractionation in all countries would be very suitable. And as a fifth point, we would really recommend the differentiation of blood and labile blood products on the one hand, and plasma for manufacturing on the other. So that would allow for the development of more targeted policies and legislation. I mean, the latest, the 2016 European Commission report and accompanying documents already reported the many different frameworks and policy initiatives with regards to the labile products and plasma for fractionation. And from our perspective, the existing differences in collection, storage, and management, as Stefan mentioned, should be taken into consideration. So we basically believe that these 5 measures would allow an increase of plasma collection and therefore benefit the availability of essential medicines such as hemoglobin replacement therapies and other PDMPs for patients with PIDs and other rare diseases. That's it.
Thank you so much. Okay. Stop. Thank you so much for staying on time as well, Leire. So the solutions that are needed for patient access, to PDMPs, top of your list, what do you want to see there in terms of these revisions?
Well, I think I mean it was very nicely pointed by Stefan, and we need to increase the collection of plasma to make sure that I mean we can, I mean the medicines can be produced. Because if they are not produced, I mean, our patient communities cannot access them. But we also think that perhaps, I mean, we support the suggestions that were included in the revision, in the consultations of the BTC legislation, where it was suggested that the monitoring of sufficiency of supply and the creation of an alert system in case of sudden supply threats, that, I mean, we support that as a way of encouraging the realization by the different stakeholders involved that there's a current problem in the lack of collection. We support the contingency or demand management plans for IGs, and Stefan said that this is perhaps a more at a national level, but we think that this would ensure that patients that are more in need and that they do not have any alternative treatments would have a prioritized access to these products in times of shortage. A bit in line with, for instance, the Wilbald-Kreutz, the European consensus proposal for immunoglobulin therapies. And we would also suggest and support an increased transparency of the process of the warning system and of the development of the contingency plans and the inclusion of patient organizations throughout the process to make sure that the next framework remains patient-centered and that it would actually meet the patient's needs.
Why are you concerned the patient's needs aren't being met? Is there a sense that they're just not being consulted thoroughly enough? Is there a reason these needs are not being met? Is it just money? Is it process? What do you think is the main problem here?
Well, I think I mean it's certainly improving. I mean in the discussions, it's improving. It can continue to improve, I would believe. And I mean patients' needs are not met because we still do not have access to the treatments we need, and especially in those cases where we cannot have any other treatment to manage the disease. I think it's blatant that I mean the needs are still there in spite of what it's done. So
okay. Leire, thank you so much. We have some questions coming in for you as well, so we'll bring those to you a little later on. Thank you so much for the clarity of your explanation today. And let's go to our next speaker today from the IPFA's perspective, Françoise Rossi. She's the Director of Scientific and Regulatory Affairs at the IPFA. Great to have you with us, Françoise.
Thank you very much, Brian. And I'd like to thank you also, PPTA and all the organizers to inviting me to this forum today. PPTA and IPFA have for long worked together on regulatory issues raised by our respective members. And IPFA and PPTA are like brother associations gathering collectors of plasma and fractionators, the industry. IPFA strive to ensure greater global and national access to these PDMPs for the patients and healthcare providers. And this is based on a preference for and commitment to the gift model of blood and plasma donation without remuneration, VNRBD. Also, IPFA supports the non-for-profit business model where there is no financial gain flowing to external or individual stakeholders. So as we saw earlier, the plasma chain goes from the donor to the patient through various ways of collection, and Dr. Karmin Saadat showed it. And we know that blood establishment collect blood components, and plasma for fractionation is a blood component. And for example, when preparing red cells for a patient in a hospital, from whole blood donation, the plasma is set aside and can be used as starting material for the fractionation into PDMPs. And this is the recovered plasma we talked earlier about. And the other way of collection is through plasmapheresis. And in blood establishment, this plasma collected through apheresis can be transfused as a lab bioproduct or used as starting material for PDMPs. So this plasma, whether it is recovered or collected through apheresis, is one and a single thing: plasma for fractionation, the raw material for fractionation. What patients need is PDMPs. What the fractionation industry need is plasma for fractionation to fractionate it into PDMPs. And what public health needs is a sustainable system for the whole blood and plasma chain and the health protection of the patient and the donors. As shown by Madam Pietikäinen, in the previous 20 years since the publication of the Blood Directive, technology, innovation, social behavior, and so on have evolved, including donor protection needs, and the revision of the directive didn't occur. So this is why, from the European Commission Inception Impact Assessment, option 2 has been preferred by most of the stakeholders. In option 2, it is expert bodies that will be able to define the rules according to the evolution of the state of the art in a flexible way. And currently, rules including donor acceptance criteria are defined by the Daughter Directive 2002-33 in Annex 3, which lists all the deferral criteria or acceptance criteria. And as it has been shown, the DQM blood guide is able to relatively rarely amend and update some of the technical requirements. In this blood guide, a deferral criteria that will not apply to plasma for fractionation is only noted as not required for plasma for fractionation. So what are those donor acceptance criteria? Well, before blood component donation is made, interviews of the donor will be able to detect chronic or relapsing affections, risk behaviors, travel in endemic blood-borne disease countries, surgical procedures, recent history of transmissible infection, and so on. And these interviews will lead to temporary or permanent deferral of the potential donor. And these measures are made to protect the donor and the patient who will receive the PDMPs. Recently, in the context of the COVID-19 and with PPTA, but in separate letters, IPFA has proposed to the European Commission in April 2020, as well as the EMA, to take actions and temporary measures in order to maintain access of patients to PDMPs in Europe. And among various recommended actions, for example, remote inspections, and we are very pleased with the outcome, the revision of donor acceptance criteria was proposed based on science while maintaining higher standards for safety of donors and patients. There were criteria to protect patient safety and were related to HIV, hepatitis A, and hepatitis B, and hepatitis C. First, let's talk about tattoo, body piercing, and acupuncture. The literature has shown that there is no increased risk of transmission of this disease when they are performed in sterile conditions by qualified persons. The current deferral period is 4 months and leads to a low return rate of the deferred donors. A 2-month deferral period will reflect the performance of the screening test by PCR of these 3 viruses. We addressed this request to the European Commission, who recommended to work with the Biological Working Party of EMA, and recently we received a reply from EMA recommending working with the European Commission in the framework of the BTC legislation, and we would have hoped that EMA would make a scientific recommendation to help that revision of the legislation. So another criterion is related to men having sex with men. For some years, IPFA has kindly requested the European Commission to publish an interpretation communication stating that whatever the national level of quality and safety of the whatever the national temporary deferral time set in each country, that the level of quality and safety of the PDMPs fractionated from these donations with national deferral various time are similar as long as they are based on national epidemiology studies. And recently, we were very pleased to receive the EMA CHMP position statement for the plasma master file certification, which actually reflects our recommendation based on risk assessment, mitigation measures, and adherence measures of these national criteria. So this is a very positive action. Those are criteria for deferral or acceptance of donors, which relate to the patient safety. But now IPFA also believes that the criteria set to protect the donor safety and well-being need also to be amended. And here we talk about frequency of donation, number of donation, volume collected, that need to be amended and according to per active period of donation. And the revision should be based on surveillance scientific data.
1 minute to go.
Yes, so there is a need to further amend the donor acceptance criteria based on science and in full respect of the donor protection. And this amendment can be done through the BTC legislation. So to recap somehow, plasma for fractionation is one and a single starting material. Whatever it is recovered from whole blood donation or collected by apheresis. Its technical requirements, quality and safety, should be equivalent. It is one thing, and it should be addressed in one body legislation of the blood component to protect the whole plasma and blood chain supply. And we recommend that this quality and safety technical requirement for plasma for fractionation be addressed in a specific section of the expert body's role that will set according to state of the art. I think that's all for this presentation.
Françoise, thank you so much. Just a quick question on this as well. You mentioned about the blood guide, the donor acceptance criteria, and it's clear from what you said that you know, the science has moved on, the technological ability has moved on. You know, my question is really why are the guidelines not keeping pace with science and technology?
Well, the guidelines, there are also guidelines from EMA, which are also somehow a little bit more connected to science, and the blood guide revision and the successive editions are also a difficult process somehow. And what we recommend, and I think that most of the stakeholders recommend that, is that as the stakeholder take part of this revision process. And expert bodies have the knowledge and the expertise of science because they follow all of that and they do epidemiological studies and they have the knowledge, but we need the industry as well, the collectors as well need to take part of the setting of the rules as it is a collective process.
Okay, thank you. Stay with us and we'll be back in a few minutes to discuss more on this. Let's move to our next speaker. Our last presentation before discussion is industry representative, industry perspective instructor Jens Rehbein. He's the representative of the PPTA Regulatory Affairs Steering Committee and also from CSL Behring. How are you, Jens? Microphone on. You're on mute. Jens, you're on mute. Can you unmute yourself there, please? There we go.
Thank you. Thank you, Brian, for the kind introduction. And thank you to the organizers for the opportunity to talk to this topic here today. I guess the burden of the last speaker is always that most of the points have already been brought up. And I guess on the other hand, the advantage is that the audience is familiar to the topic and to the specific and somewhat peculiar vocabulary of it. First of all, I want to say that I think in general, the regulatory environment in the European is already very good. The concept of the plasma master file that was already mentioned by Karmin, Saadat and others, which is a standalone document only or exclusively describing the human plasma as a starting material for human medicines that can be manufactured out of it, already made the regulatory management of human plasma as a starting material much easier. However, as with all good ideas, I believe there's room for improvement, especially after long years in which there was very little progress. My impression and the impression of others is that over the years, the regulatory procedures about notifying the authorities of changes in blood and plasma collection organizations became much more rigid and do not match anymore the dynamic landscape of blood and plasma collection centers, especially in a time where various member states are experimenting or evaluating new ways of increasing the volume of collected plasma in order to meet the patient's demands in their country. Notifying relocations, for example, or opening of new centers or the addition of new organization in the context, for example, for local or national toll and tender businesses should be much more expedient. They should be more flexible, and there should be fast and pragmatic, efficient processes and regulatory procedures in place that make sure that the plasma collected by the organizations in these regions or nations can enter the manufacturing process in a timely manner. The current ongoing revision of the respective directives also provides us with an opportunity to differentiate between blood collected for transfusion purposes and the collection for plasma-derived medicinal products. And with the differentiation and the definition of which is which, it would also be good to set up a system, and I think that was already said by Françoise, that would allow to adopt the requirements for both these kinds of blood or plasma from further manufacturing to current state of the art, to current technical developments and scientific knowledge. And also, of course, to unexpected challenges like the one we are currently in, the pandemic and the new emerging virus. Last but not least, I think it's important that we have a system in place that also the donor eligibility criteria maybe or especially adapted to the intended use of the blood or the plasma match the current scientific knowledge and the technical development. Some of these requirements date back 20 years nearly and were based on technical possibilities that are far advanced now. If we look, for example, the PCR or nucleic acid testing, which is very familiar to everybody in the current situation, can now detect much lesser virus loads. The regulatory context or the regulation should also take into account, I think that were also mentioned by Françoise, the ability of the manufacturing process that have various steps designated to remove or inactivate known and emerging pathogens. And all these steps have been demonstrated in various validated studies. In general, a setup which would allow a fast adoption to challenges like emergent viruses or emergent pathogens, but also to new technical developments would be much appreciated by all involved parties. I also believe that it would be beneficial if we align the donor eligibility criteria or the criteria for plasma for fractionation and plasma or blood for transfusion between different member states, but also between the European Union and other countries. Tiny differences in the requirements, although based on the same scientific knowledge, might result in major burdens from a logistical, regulatory, and manufacturing point of view. Yeah, that was pretty much my take on that in a nutshell.
Thank you, Jens. We like nutshells, it's good. Especially, we want to keep on track for time here as well. Just a quick question before we go to the panel. For you, from the industry perspective, what would an optimal regulatory framework look like from an industry perspective?
One part for sure would be a flexible approach for the maintenance of registration dossiers, marketing authorization dossiers, especially, of course, the already mentioned plasma master file. For example, the collaboration with local or national organizations in context of toll or tender businesses, they require frequent update of the information for these plasma organizations, not only addresses, but also blood bags and test kits and things like that. And I imagine a regulatory framework that would allow a fast update, pragmatic update of this information, allowing or avoiding hurdles for pickup, delivery, manufacturing, and subsequently supply to the patients without impacting the quality or the safety of the products.
Thank you. Those succinct Excellent. Let's go to some questions, and we have a few for Stefan. We're going to broaden them out here. There's one question from B. Omen, and it's to Stefan on a particular slide. Stefan, if everybody can all the speakers switch their cameras back on, that'd be great, please. Stefan, so the question is on the slide: interruptions and opportunities to increase supply. Healthcare workforce not mentioned. Is there enough done on recruitment and staffing, doctors and advanced specialist nurses, to invest in this health domain? And is this also an element to include in the long-term investments because there's already a shortage in health professionals? Stefan.
It's a good question and an important question, but obviously this is much broader than just the field of blood collection and blood transfusion. But it's true. I think we realize in many countries and in some public systems we see some lack and gaps in sufficient staff available. But I must confess, as Commission, this does not really fall in our mandate. I think it's important to be clear that the organization of healthcare, and that includes how member states decide to collect plasma or how they decide to let it be utilized, the derivatives, that's really a national decision. That's not something we are interfering with. But that being said, we have colleagues on a non-legal basis that are working on healthcare staffing across the EU, but this is much broader than the blood and plasma field.
Yes, for sure. Like you say, it's on a non-legal basis. And one of the things the Commission does well in this context is to benchmark standards as well. So perhaps the benchmarking of the supply of specialized healthcare staff in this regard is a way forward. Thank you, Stefan. So a question here from Jens Reinhardt. It says, there is, however, also the fact that most of the plasma in the EU is collected in only a few member states. Is there a way to tackle this? Stefan touched on this earlier. Jens, do you want to comment on that?
I guess he's referring to the 4 member states that were actually already mentioned by Karmin Saadat from the Austrian authority. It's Austria, Germany, Czech Republic, and Hungary, to my knowledge.
Yeah.
And it's those countries that actually allow compensation for donors.
Okay, thank you. Question here from Martin van Bellen. And the EU Pharma Strategy aims for measures to tackle root causes of shortages. Should the Commission also not tackle root causes of lacking plasma collection in the EU instead of strengthening supply monitoring? What can the Commission do to increase plasma collection in Europe? Stefan, you have a go at that, and then ask somebody else as well what you should be doing.
Okay, thanks. Again, the starting point is what the member states decide on how plasma is collected in the EU. And I think it's very right what was said before, that there are a few countries, and there are only a few countries in the EU actually where private actors are allowed to be very active. In the large majority of the EU countries, this is a role considered for the public sector. Again, this is not something that we as Commission are interfering with. That being said, I think we see on both sides efforts to improve the collection with those countries with private actors, but also in those countries with public actors. We see increasing interest. They have those public blood services have a very large donor base. We see an increasing interest and efforts to shift some of those donors into more plasma donation. I think one thing that has confirmed or shown that a little bit is also the COVID experience, where by coincidence there was a potential therapy based on plasma, and that has led many countries to participate in a scheme to help their public services to strengthen the plasma collection. So again, this is something not legal. It is not a member state and a EU decision to be taken. It's national decision, but based on their national setups, we can try to see how we support them on a voluntary basis driven by the member states.
The monarchy in England has the right to advise and the right to warn. I think the Commission maybe has the capacity for the same direction in this regard. Thank you. Françoise, on the same issue, and then maybe a quick comment from the regulatory side from Karmin. Françoise, how do you see this? Should the Commission take there are limitations here in terms of what they can do, but how do you see this in terms of what the Commission can do to increase plasma collection in Europe?
I think that the European Commission has already made a big step by creating this emergency support initiative and providing the public sector with equipments, and that will remain, hopefully. This is a strong encouragement and actually an action finally taken based on the recommendation of the directive to collect in blood establishments, and no support up to that had occurred. So indeed, the public sector experienced a delay in providing plasma for fractionation. So now it is on, and I believe that many countries will be able to collect more plasma for fractionation. And there is also the wastage of the recovered plasma, and if the European Commission could find ways of supporting contract manufacturing within Europe, that would also help.
Thank you. Karmin, from your perspective, is there a regulatory role here that is there something you see which would, if changed in terms of process and regulation, would help the increase the plasma collection?
Well, I think everything has been said already.
Okay.
I don't really have anything to add to what the speakers before said. I guess Jens said that compensation is a big factor, obviously, but then as Stefan mentioned, it's up to the individual countries to decide on whether or not they want that. So I can't really speak for them. Yeah,
that's fine. Just a slight tangent to the same question. This one is directed to Leire. The question, I don't know who this is from, but it says, there is, however, also the fact that most of the plasma in the EU is collected in only a few member states, as we've said. Is there a way to tackle this? Leire, how would you want this tackled? The wider approach across the EU?
I mean, I think, as some of the speakers have already said, there are already best practices in some of the countries where they are collecting in Europe, that they are collecting more. So I think perhaps learning from those best practices could be a way of improving the collection of plasma.
Okay, thank you. Comment here from Kirsten Seidel. From 2018 to 2020, I participated in the Transpose project of the EU, where we revised the EU directive and established new guidelines, also on plasma for fractionation. What happened to the proposed changes to the guideline? Why are they not considered when we speak about the revision of the EU directive? I'm going to take a wild chance that you might have an answer to this, Stefan.
I think they are considered, but these are technical suggestions again on specific donor requirements, and there will be considered in wherever the technical requirements are being set. At this moment, they are already considered in the developments of the guides by EDQM. Their work, there's a iterative work that takes 2-3 years to make a new version of the guide, and the outcomes of Transpose have been transferred to them, and they will be taken into account there.
Thank you. Question for Leire. This is from Jackie Kerr. Jackie asks, are the survey results on the shortage of PID patients publicly available? Could you say something about the exact numbers of those who did not receive products due to COVID shortages? Thank you, Jackie.
Thank you, Jackie, for the question. Basically, we are still receiving answers from some of our national patient organizations. What I took was only the data from the EU, because we launched the survey at international level, and we are still receiving the data. So once we get all the data and we finalize receiving answers, we will be preparing some type of information to be disseminated.
Okay, thank you. Question from Angelica. Just to summarize this, among the challenges experienced during the COVID crisis was a decrease in blood donations. The EMA and the WHO have stressed the importance of patient blood management as a way to reduce unnecessary transfusions, and the ECDC strongly advised the implementation of BPM. How many acronyms can we get in here? In order to address blood shortages, will the EU Commission and the Parliament consider including the concept of patient blood management in the new legislation in order to better manage European blood supply? Stefan.
Very interesting question. This is just to make clear, right, this is outside of the scope of
Sure.
plasma and plasma utilization. We have done in the past, as Commission, we have supported a project to identify and share good practices in the field. It is true that there's an overall trend with the clinicians to use blood more selectively and a bit less than in the past. That's also why we see a slight decrease in overall utilization of whole blood, of other blood components, sorry, not whole blood, but red blood cells across the EU. But again, this falls under the mandate of the local mandate of how therapies are used. And so this is not something we can legislate at EU level.
Okay, thank you. Another couple of quick questions. I'm going to go to your soundbite wrap-up. So from Suzanne Hastrup, she says, to increase source plasma collection in the EU to become independent from the US, we need to discuss adequate compensation of donors to attract sufficient donors. Is Europe ready to discuss a solution to this current hurdle? Karmin, what do you think? Is Europe ready to discuss this?
I can't speak for all Europe. I just presented Austrian's take on it, and you know there are it's been discussed controversially, of course, also. So it's not just a clear-cut option to just you know open up centers and compensate. I think one of the comments in there just very critically said something about the compensation in Austria being excessively high. And well, yeah, so there are discussions. It's not just positives. So I guess every country has to talk about this, but I think it is the main driver for you know plasma for fractionation, definitely.
Okay, thank you. And just to follow up on that, Karmin, also, Pierre Bork says, hi from Blood Flow Inc. Are EU regulators and the European collection industry ready to open to technological innovation in donor engagement to better incentivize and motivate the plasma donor base? Technological innovation. Karmin, what do you think?
Yeah, I don't really know what that refers to.
Okay, anyone else? Jens?
Can't think of anything.
Yeah, I also have a little difficulties understanding what it refers to, but I believe that everybody is working on collecting the plasma as efficient as possible, looking, for example, at the rigid definitions of the amount of plasma that you can donate just based on weight, things like that. Something I could imagine.
Okay, I would want to pursue that a little further, but we're out of time and in terms of mRNA and other new devices which increase the testing capacity, things like that. We don't have time for it, unfortunately. I'm just going to ask each of you to do 20-second soundbite, and then we hand back to MEP Pietikäinen. And really the question to each of you is your key message today. What needs to be done to make plasma collection more efficient in Europe? Let's start with Jens.
I think we have a great opportunity at hand to set up flexible and pragmatic regulatory environment or frameworks with a differentiation between transfusion products and plasma for further manufacturing, as well as the respective donor eligibility criteria for both of them. Main goal should be the removal of hurdles for both public and the private sector to ensure the supply of much needed medicines to the patients in need.
Thank you. Françoise.
Yes, thank you. First, the flexibility of amending all these technical requirements and rules, including inspection, should be the pathway, the flexibility pathway should appear in the revision of the directive. Then an immovigilance framework should be put in place. Then the donor panel would be better known, and that will improve the accessibility of donations. A very important thing is to have to reach a strategic independence in Europe, to become less dependent of third country like the US, and to have the starting material plasma for fractionation set as a strategic resource in Europe at least.
Thank you.
And taking into account the fact that that this plasma needs to be taken into the whole plasma and blood chain supply, and because they rely on each other, they could be they are dedicated plasmapheresis centers, but the whole thing is the whole. Thank you.
Thank you, Françoise. Karmin, 30 seconds. What needs to be done next?
Well, I think what we're going to do is, or what's being done right now is updating the donor deferral criteria. This is definitely a very important point. Keeping that up to date and making sure that donors do not get deferred for no reason. At the same time, maintaining donor safety and product quality. I think that could lead to a lot more amount collected, for sure.
Thank you, Leire.
Thank you, Brian. So basically, science and technology to be the drivers of the revision, plasmapheresis programs on avoiding wastage of plasma, learning from existing best practices in some EU member states, and to reiterate the urgency to ensure that more plasma is collected so patients dependent on plasma-derived medicinal products have access to the treatments they need.
Thank you. Stefan, last words. What needs to be done?
Thank you, Brian. I think I said it's not one single action of one actor that's going to be giving the golden answer here. There's many actions to be taken by many actors. I think speaking for us as regulators, I think our job is a lot about organizing flexibility and facilitate access to safe therapies. That's in the end our objective, and that's also what the whole revision on the blood legislation is about. But I think, as we saw, that also is and does and should apply on the pharma legislation and on the link between the two legal frameworks. But that's of course only the regulatory point of view, because even if you have the best legal framework, it still needs to happen in the field, and the actors need to do their part. And I think there's a big role here for both, for the private and for the public collectors.
Excellent, thank you. Let me bring back in MEP Pietikäinen. You there?
I'm here.
Excellent. So let me give you the floor. So maybe you just want to respond quickly to some of the comments you've heard, and then I'll leave the floor to you to give the closing remarks as well. Thanks for joining us today.
Thank you very much. And first of all, let me extend a special thank you to all of our panelists and speakers. This has been an excellent food for thought for us decision makers, because we need to be very well prepared in European Parliament when we are going to handle with this regulation when it comes in front of us. And then it is very important to have very balanced and diverse knowledge. So thank you, you really provided that information. And a special thank you to you, Brian McGuire, who excellently leaded this panel to be in time and to focus on interesting points. So it was a pleasure to listen to you. And I'm not trying to conclude and draw together all of the conclusions what was discussed, but maybe some ideas that were sort of very attached to me when I listened to the whole panel. Firstly, I guess that cautiously, step by step, we would need more Europe and European level regulation and actions on this level when it comes to EU Blood Directive and when it comes to definitions and organizing the collection and maybe compensations and other parts, knowing it is in the competencies of member states. And going there, what about, and I'm not proposing it directly, but if we would study this kind of a patient organizations, Red Cross-based collection system, where actually the incentives would go instead of a direct person and donor to that donor organization for it to campaign the collections and organize the blood collections and plasma collections, and then give the incentives, but not so that we would have that kind of a distortive incentive for poorer people to be the special group of donors. It could be like in some other cases, for example, extra medical checkups or nutritional guidance or free card to a gym or whatever. So it wouldn't be sort of not so much linked to directly on donation. Plus, then this of course should be decided on the basis of donor panel proposals. Then my third point would be that we need to introduce a clear differentiation between whole blood and blood components for transfusion and plasma for manufacturing of PDMPs. And we have to take up on this regulation and practices the old knowledge what we have gotten already from the science and improved technologies to qualify the different kind of sections to be used. And indeed, we would need to be revising the existing eligibility criteria for plasma donors based on this newest technological and scientific progress. And these criteria should take into account the ability of the manufacturing process to remove the known and emerging pathogens, thus ensuring the highest quality and safety of the final product that of course and indeed would need to be secured. Well, many other issues still left, and I'm sure that we are going to meet each other in different combinations and going to continue the discussion about the PDMPs, the plasma donations, and the whole EU Blood Directive and its renewal. At this point, I only would like to extend a great and warmest thank you also to all participants and wish all of you the best and happiest springtime, and of course have a nice evening.